What else? Anything else that has your eyes or your interest in the relapse setting?
Well, of course, I mean, the toxicities of ACER were really manageable, and it's now regarded as a category 1 because of the, it was a larger study and was well conducted. And so I agree, I'm on the NCCN guideline, and so we put it as category 1 because of, how it was conducted, and not much of a toxicity either, apart from the pulmonary, and no prophylactic regimen were given on that, on that study. I know they had about 20 to 28% of pneumonia and bronchitis and upper respiratory infection. So do you give, prophylactic treatment, or that's something that could be considered when we give patients this, this treatment? And otherwise it was well, tolerable. So the other drugs, that was really that targeted therapies, CAR T. So that's the area now of great research and discussion. And I think that's where we're heading to in terms of for relapse. So the antibody drug conjugate belantamab, in fact, just yesterday, the FDA gave an approval of 12-0 vote to proceed, for a discussion regarding FDA approval for belantamab as a single agent. Yeah, that's great. So the the study that was published as a single agent, but the DREAMM-2 study looked at belantamab with bortezomib dexamethasone, or belantamab with lenalidomide, dexamethasone. So at ASCO, it was the belantamab Velcade-dex was presented, 59 patients. And of that, the overall response rate was 78% with a VGPR better of actually more than 50%. And clinical benefit, of course, when you've had multiple relapses, you always look at stable or, MR clinical benefit was 83%, for, the dose of 2.5 milligram per kilogram. And, it's well tolerated. It's given every 3 weeks. The eye problems, we participated in the DREAMM-2 study, is not a big issue at all. It's manageable by them actually seeing ophthalmology first, or even during, and some patients just use eye drops, for that. So it's, I'm excited about, belantamab being, and of course the CARTITUDE study by Nikhil Munshi, the BB2121, study that showed really, what, 90, almost 100%, 97% response, or even higher, but the cytopenias in that were also very high. 97% had cytopenias. So we're really starting the surface of the CAR T, and in that study also CARTITUDE, equated to gratitude, right? So in patients who are having 3 or more prior lines, and these are patients who've had like up to 18 prior lines of therapy, seeing some clinical benefit in those studies, and the quality of life was also assessed, which was also better with the studies. And then last but not least for me was the bispecific antibody teclistamab that was also presented at ASCO, 66 patients, and showed a really up to 78% response at the highest dose of 270 microgram per kilogram. So really exciting, and management upcoming. Of course, the cytokine release syndrome and the neurotoxicities are usually things that need to be discussed and managed with the patient. So I'm curious to hear your thoughts about all these new drugs.
Yeah, I am amazed on where we're at.
Yeah.
And you beautifully described those three classes, the ADC, the CARs, and the bispecifics that are now targeting BCMA, but there are going to be other targets, right? In similar types of novel immunotherapies. We also, for belantamab mafodotin, haven't had a big problem with the ocular toxicity. We have a good relationship with our ophthalmologist.
Mhm.
It hasn't been problematic in terms of dosing. I'm very curious because they have a randomized trial now where they are going to go head to head against a variety of different agents, including daratumumab,
Yeah.
belantamab Veldex versus Dara-Veldex. It'll be interesting actually to see that. And then there's a RVD versus belantamab RVD. I'm curious to see the results of that one too. I do think the dosing, we'll have to figure out the dosing. In terms of the CARs, we're all excited about the CARs, but at the end of the day, it's not lymphoma where the CARs, last for a tremendously long time and maybe forever.
I agree.
And myeloma, at some point, it seems like everybody's going to relapse. So I think the take home point in terms of the CARs for me is that it's not going to be we are hoping a one-time dose of CARs and that's it. They don't need any therapy. So we have to figure out what maintenance to give afterwards. And also, if and when they relapse, what to give them as salvage therapy.
Right.
I'm actually I gave the kind of the review of teclistamab at ASCO Virtual, and I was really impressed by the data. So we have 3 bispecific T-cell engagers that have shown, response rates, more than 50%. We had AMG 420, we had the BMS CC 93269, and then we had teclistamab. Basically the BMS therapeutic and also a teclistamab, some of these patients are actually out more than a year in continuous remission, and they're looking durable, and they continue to get therapy. And there's less, there's a little bit less CRS with CARs. 80% or more have, CRS. With BiTEs, maybe it's 50 to 60%. And less neurotoxicity. It might be that, a monthly dose of a bispecific might be the best therapeutic out there. Single agent, no steroids. For me, it's pretty amazing. And then at the end of the day, can't we all get along? Maybe we use them all together. Maybe they get an ADC as frontline therapy, and then a CAR as consolidation instead of a transplant, and then a BiTE as maintenance after that. It's going to be really fun.
In fact, some of the things that the BMT-CTN is looking at is maybe how do we, incorporate CAR T, just like in the lymphomas, there was a randomized trial looking at CAR T versus autologous transplant. So that study completed. We'll see what the results are. But, some of the things in high risk, and we incorporate CAR T in high risk as a consolidation after autologous transplant, or patients who post-autologous on maintenance and haven't reached either a PR or less, can they benefit from an addition of CAR T? It'll be interesting to see. My only thing with the CAR Ts, even with the lymphomas, is the cytopenias. This patient can have cytopenias even up to 6 months and need transfusion. But again, it's still early in the game. I'm sure they'll be making changes in these constructs, and then making them better and less cytotoxic. So it's exciting that we have so many avenues and different things to look at for myeloma patients, improving their survival.